Electrical axis can be calculated for the P wave, QRS complex or the T wave. It can even be calculated for the segments like ST segment, though it is seldom done. Most often, only the average QRS axis is calculated, and when electrical axis is mentioned, generally only mean QRS axis is meant. QRS axis can be altered in various disease states like intraventricular conduction defects, myocardial infarction, chamber hypertrophy, and change in position of the heart. For calculation of mean axis of the QRS complex, the amplitude of the negative waves is subtracted from that of the positive waves while plotting on the graph using lead 1 as x-axis and AVF as y-axis. Another method is to check the lead in which transition from positive to negative QRS occurs using the hex-axial reference system. The axis is perpendicular to the lead in which equiphasic complexes are seen. The axis of lead 1 is taken as 0 towards the left and plus minus 180 degrees towards the right, that is negative pole of lead 1. The axis of AVF is taken as 90 degrees downwards and minus 90 degrees in the vertically opposite direction. Mean QRS amplitude of lead 1 and AVF are plotted along the corresponding axis and the resultant taken as the mean QRS axis. Illustration of determination of QRS axis using lead 1 and AVF. In the hex-axial reference system, each lead is assigned an axis for its positive pole. The negative pole will be diametrically opposite to it. Mean QRS amplitude in each lead is checked to see if there is a lead which is equiphasic. If so, the QRS axis is taken as perpendicular to it. For example, if the equiphasic complexes are found in lead 1, QRS axis is 90 degrees. It will be plus 90 degrees if AVF is positive and minus 90 degrees if AVF is negative. In this case, AVF will show the longest QRS complex as the QRS axis is along this lead. If no lead is seen as equiphasic, leads in between which the QRS transitions from predominantly positive to predominantly negative is checked. Suppose it is between lead 2 and AVF, then the transition is at plus 75 degrees. QRS axis will be minus 15 degrees if lead 1 is positive and plus 165 degrees if lead 1 is negative. Hexaxial reference system used for determination of electrical axis. The positive poles of the leads are marked by the arrows. Normal QRS axis is in the right lower quadrant between lead 1 and AVF. If the axis is in the left upper quadrant between lead 1 and minus AVF, it is taken as left axis deviation. QRS axis up to minus 30 degrees is taken as minor left axis deviation or leftward axis. QRS axis in the right lower quadrant between AVF and minus lead 1 is right axis deviation. At a glance, if both AVF and lead 1 are positive, the QRS axis is normal. If lead 1 is negative and AVF is positive, it is right axis deviation. In left axis deviation, lead 1 is positive and AVF is negative. If both lead 1 and AVF are negative, it is indeterminate or northwest axis. This could be either extreme left axis or extreme right axis deviation. Calculation of P and T wave axis are similar but seldom done and more difficult because of the smaller amplitude of the waves. Difference between the QRS and T axis has been called the QRS-T angle, which is widened in ischemia. Illustration of computerized ECG recording with automatic display of calculated P, QRS and T wave axis in a clock-like diagram beside the measured values in the top panel marked by red arrows. The display also shows the axis of standard leads 1, 2, 3 and augmented leads AVR, AVL and AVF. The numerical values for the P, QRS and T wave axis are given in the measured results in the left upper corner marked by blue arrow. P wave axis is given as 20 degrees, QRS axis as 20 degrees and T wave axis as 10 degrees. Hence the QRS-T angle will be 10 degrees. Soclow voltage is displayed as 3.6 millivolt. Sinoatrial conduction abnormality could be first degree, second degree or third degree SA blocks. But it is not possible to identify first degree and third degree SA blocks on the surface ECG as the sinus node activity is not visible. Theoretically, first degree SA block would mean prolongation of SA interval with regular conduction, and third degree SA block would mean total absence of SA conduction. Second degree SA block could be either type 1 or type 2. In type 1 SA block, there will be progressive prolongation of SA interval followed by blockage of one P wave. This will manifest as progressive shortening of PP interval followed by a pause. But the pause will not be exact double of regular PP interval. In type 2 SA block, there will be sudden blockage of a P wave so that a sinus pause exactly twice the regular PP interval will be noted. Sinus arrest is a sinus pause which is more than 1.5 times the regular PP interval but not exactly twice the PP interval. There is no preceding progressive shortening of PP interval. Sinus arrest or pause could be a defect in the automaticity of the sinus node. ECG rhythm strip documenting a long sinus pause of around 8.5 seconds. Such long pauses are a manifestation of sick sinus syndrome. Central monitor record capturing a long pause of about 8 seconds and two pauses of around 2 seconds. The underlying rhythm is atrial fibrillation as no P waves are seen and there is some QRS widening with a notch.